Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 41. Blood loss. I hesitated thinking about the title of today's episode. The original title I was going to use was hemorrhage. Hemorrhage is a word we use a lot in obstetrics, but I wondered if that might be quite a scary and off-putting word. Hence the fact I decided to talk about blood loss instead. But it made me think about the fact that we use the word hemorrhage on an extremely frequent basis in maternity, and how that might be perceived by the women and families we're looking after. I'm going to focus today on postpartum hemorrhage, that is blood loss after the birth of the baby. Bleeding in childbirth is a very significant health problem worldwide. If you look internationally, 21% of maternal deaths are due to excessive bleeding, and 2/3 of these are bleeding after the birth of the baby. We're very fortunate in the UK, in the NHS, to have ready access to blood products and blood transfusion. A lot of those deaths worldwide are due to lack of access to those sorts of resources. That's an incredibly sad fact. Fortunately, in the UK, when you look at the maternal mortality rates, hemorrhage is quite low down the list these days. In some ways, it's been a success over the course of my career, the reduction of maternal deaths from hemorrhage, from bleeding, such that the rate of death in the UK from bleeding is 0.6 per 100,000. That's extremely rare, an average of 14 deaths every 3 years. But you could argue that that's still 14 deaths too many. Should any woman in the UK be dying from excessive blood loss? Why am I choosing to talk about blood loss if it's so rare that it causes a woman to die? Well, that's because it's increasingly frequent. Rates of blood loss are dramatically rising. So let's break it down and think exactly what do I mean by hemorrhage or postpartum hemorrhage. The classical definition of postpartum hemorrhage is the loss of 500 millilitres, half a litre of blood, immediately after the birth of the baby. That's about a pint. Doesn't sound too bad. Women having babies expect to have some blood loss after the birth. When you look at the National Maternal Perinatal Audit that I've referred to in previous episodes, 34% of women in the UK will have a blood loss equal to or more than 500 millilitres immediately after the birth. That's not too worrying. What is more worrying is that approximately 3% of women, so 3 in 100, will have a blood loss of 3 times that amount or more. 1.5 litres, 1,500 mils. Why is that, and why is that important? Part of the reason this happens is because during pregnancy, the mother is sending large amounts of blood to the womb, to the placenta, to supply the baby. Blood is passing through the placental bed at a rate of 500 millilitres a minute. That's half a litre a minute. This is important when you consider the average blood volume of an average size woman. The total blood volume of an average woman will be somewhere between 5 and 6 litres. That means in any minute, 10% of her blood volume is going through the placenta. Okay, I'm talking about the placenta, but at the beginning I said I was going to talk about bleeding after the baby's born, postpartum bleeding. Why is the placenta relevant? Immediately after the baby is born, the placenta, the afterbirth, has to separate from the wall of the womb. So that blood flow, 10% of her blood volume every minute, has to abruptly stop. And that doesn't stop by her body suddenly not sending the blood to the womb. It stops by the blood vessels in the womb being constricted. So the most important change that needs to happen as the placenta comes away is the womb has to suddenly contract down to constrict all those blood vessels and stop that blood just simply spilling out and pouring out of the woman. Nature's an amazing thing. The womb literally goes from being big enough to contain the baby to being pretty much half the size almost instantly when the baby is born. This is due to the womb's response to the same hormones that are required during labour. Remember, in the episode on induction, we talked about oxytocin and prostaglandins helping the womb muscle contract. And it's exactly the same after the baby is born. One of the commonest reasons for a woman to bleed is because the womb hasn't contracted. The womb may have been tired. She's been in labour a long time. Or the womb has been overstretched. Maybe the baby was quite big. Or maybe there's something within the womb, like a fibroid, a growth of the muscle of the womb, that is preventing the womb from contracting down and constricting those blood vessels. So the commonest cause of bleeding after a baby is born is what we call tone. The womb is tired, it's not properly contracting. The first thing we can do is rub up a contraction. This sounds completely mad, but the womb is very responsive to being touched. And if we rub the woman's tummy or press on the womb, sometimes called bimanual compression, press from her tummy and from the vagina, the womb starts to contract. You can actually see this at caesarean section. It's completely fascinating. The womb is smooth, pink and soft when it's not well contracted. And as it contracts after the baby comes out, the womb becomes white, blanched and kind of crinkly looking. You can see little wrinkles in it. And when you touch it, it's firm. It's the most incredible organ. Because tone is one of the commonest reasons that a woman might bleed, there are lots of things we can do to help prevent that. And this is why doctors and midwives recommend having an injection after the birth of the baby to aid separation of the placenta and help the womb contract. If this doesn't work, or if the woman doesn't have that injection and then starts to bleed, we will usually give medication to help the womb contract down and constrict those blood vessels. These might be oxytocin in a drip or an injection of a prostaglandin. If the bleeding is bad, there are also mechanical things we can do to put pressure on the placental bed where the blood flow is to try and prevent bleeding. This might be a special sort of brace stitch that literally looks like a pair of trouser braces to hold the womb compressed. Or it could be putting a balloon inside the womb. That's like a large balloon that you blow up with some fluid that compresses the placental bed. A bit like if you cut your finger, you put pressure on it to stop bleeding. The balloon sits inside the womb and puts pressure on those blood vessels to stop the bleeding. I've said that tone, the way the womb contracts, is one of the commonest causes of blood loss. What are the others? Well, in maternity, we like things simple, so we talk about the 4 T's. Tone, which I've discussed, tissue, trauma, and thrombin. So I will now explain the others. Tissue is when there's something left inside the womb. This might be clots that have built up, or this could be that the placenta hasn't come out or part of the placenta hasn't come out. Having a retained placenta is a common cause of bleeding. The womb can't contract down and constrict those blood vessels because the placenta is in the way. So one of the things we do when a woman is bleeding excessively is check the placenta, have a look, see does it seem complete, and also try and examine the woman to see whether all the tissue is out. Sometimes it can be hard to tell, or sometimes it's obvious because the placenta hasn't come away at all. Usually we'd expect the placenta to separate and come away within about half an hour of the baby being born, and certainly within an hour. If it hasn't, we know that that woman is at risk of bleeding, and therefore we need to take her to theatre to sort it out. Removing the placenta is done in theatre with an anaesthetic, usually a spinal, so that the woman is awake and can spend time with her new baby. And the procedure is called a manual removal of placenta. It's the most veterinary procedure that we do. I don't know if any of you watched the recent James Herriot series, All Creatures Great and Small. When I was a child, it was on television, and the vets usually would turn up and help a labouring cow or horse by sticking their entire arm up inside the animal and pulling out the calf or foal. It sounds terrible, but manual removal of placenta is a bit like that. The safest way to remove the placenta is literally to reach in and pull it out, not with instruments, not with anything technical, but with our hands. It's quite a tricky job, but what you need to do is feel your way, feel between the wall of the womb and the placenta, and use your fingers to gradually tease it out and separate it, and then pull it out. It's a very simple procedure that doctors often learn to do at an early stage in their career, but it can be immensely satisfying. Once you've removed the placenta, you can check that the womb feels completely empty and you can stop the bleeding. One of the best descriptions I've ever heard of a manual removal of placenta was from a partner of a woman I looked after. He described it a little bit as seeing his wife being like a glove puppet. It's an image that has stayed with me. It's quite a good analogy. It sounds very graphic, and if you're a woman, you may not like to think of it like that. But actually, it's quite a gentle procedure because we're gently feeling our way. And the woman doesn't feel anything because she's got good pain relief. It's being done in theatre. Next, we need to talk about trauma. What do I mean by that? Trauma may be vaginal tears, either a cut that we've made, an episiotomy, or a tear. And this may be from the birth of the baby. Babies that come out perhaps with a compound presentation, that means with an arm coming with the head, or coming out quickly, or coming out in an uncontrolled way, can cause a tear, and tears will often bleed. Unfortunately, there are also tears that are of our making. Tears are certainly more common with instrumental birth, that's assisted birth, and particularly with forceps births. That isn't due to the forceps themselves. Actually, forceps are a very safe way to deliver a baby, and I will talk about instrumental birth, perhaps next week. No, the tears are our fault from the way we've applied the forceps. The way we put the forceps around the baby's head can traumatise the mother and cause a bad tear if we don't apply them in the correct way, protecting her as we place them around the baby's head. We can also cause trauma at a caesarean, particularly if it's a caesarean in the late stages of labour. The womb has been working hard and can tear quite easily. It's very fragile when the womb muscle is exhausted from labour. Or it can be that when we're cutting into the womb at caesarean, we're going through the big blood vessels that are feeding the placenta directly. Sometimes when we open the woman's abdomen and look at the womb, you can see big fat blood vessels the size of your finger spreading across the front of the womb, and we know that as soon as we touch them, she's going to start to bleed. The most important thing then is for us to communicate this to the anaesthetist, get the baby out quickly, and as soon as we've got the baby out, to clamp those blood vessels as quickly as possible so that we minimise the blood loss for the woman. The only way to deal with bleeding from trauma is to stitch it. Stitching things together, bringing things back together, or stitching around blood vessels that are bleeding, quickly bringing things under control. Sometimes it seems to me bizarre that some thread, some stitching and some knots can literally be what helps save a woman from a significant bleed. But the quicker you get on and stitch, the quicker you repair whatever trauma has happened, the less blood she will lose. Finally, we come on to thrombin. Thrombin means how blood clots. Thrombin is one of the proteins in the clotting cascade. The first thing we do now when any woman is bleeding is give her something called tranexamic acid. This is a medication that helps the blood clot more quickly and therefore minimises the blood she loses. The quicker we give it, the more effective it is. The other reason that blood clotting can be a problem is that if you lose a considerable amount of blood, not only are you losing the red blood cells that carry oxygen, but you're losing the plasma, the proteins that help the blood clot too. When you replace blood by giving a blood transfusion, usually what we give is packed red blood cells. This brings the woman's blood count back up and helps give her circulating oxygen. But if she's had an extensive amount of blood loss, she also needs plasma. This contains the clotting factors. Sometimes we can see a visible change if the woman loses a lot of blood in the blood that we're seeing come out. We can actually visibly see it getting thinner and clotting less. And then we know we have a clotting problem. It used to be standard that once we'd transfused a certain amount of packed blood cells, that we would be issued with plasma as well. Now it's more common for maternity units to have a machine that will do a point of care test. That is a test in the operating theatre or very nearby the woman that rapidly tells us what she needs to improve her clotting. One of the most important things in making sure that her blood is clotting effectively is to keep her warm. If a woman gets cold, either because she's exposed on the operating table or because we're giving her replacement fluid that, although it's at room temperature, is cooler than her body temperature, she will progressively get cold. And as she gets cold, the clotting cascade doesn't work as well. So that's why when we give blood that's come from a fridge, we give blood through a warmer. This warms the blood before it goes into the woman's veins. We'll also put a thing that looks like a big puffy set of bubble wrap on top of the woman, called a bear hugger. This literally blows warm air into a kind of duvet over the woman so that we keep her warm. It's important not just for her emotional well-being to feel warmer, but for her physical well-being as well. Managing blood loss, a hemorrhage, can be very stressful. When I first started as a consultant, if a woman lost 2 litres of blood, so approximately 30% of her blood volume, this would be declared a serious incident, and we would do a very detailed investigation into that blood loss, why it happened, and what lessons we could learn from it. The rising numbers of hemorrhage mean that this just isn't the case anymore. It doesn't mean that we don't look into it. Of course we do. Particularly when a woman has lost sufficient amounts of blood that she needs intensive care or is significantly unwell from the after effects. But blood loss on that scale is becoming more commonplace. Obstetrics is different from many other areas of medicine. In other areas of surgery, that sort of blood loss is unusual. I often say to medical students when they come to maternity and they want to come to theatre, how are you with seeing blood? Obstetrics is messy. There can be blood on the floor, blood on our shoes, blood in a bucket at the bottom of the bed. And I think this is a problem because we can get too desensitised to that rate of blood loss. This is particularly because our patients are fit, healthy women, for the most part. A healthy pregnant woman can sustain quite a significant blood loss before she starts to become unwell. This means we can sometimes be a little bit slow to realise what's happening. Some bleeding is obvious. It's called revealed bleeding. The blood is visible. We can see what's happening. More difficult is concealed bleeding, where she might be bleeding from the womb inside her abdomen, but we can't see it. Or the blood has been coming past us, but it's been trickling, so we haven't noticed just how much blood volume she's lost. As a trainee obstetrician, I used to sit stitching a woman after a birth, and I would notice the blood trickling down as I did the stitching. Then a woman would start to say, I don't feel great. She might feel sick or she might feel faint. And I would suddenly see the colour drain from her and realise that actually the blood that was trickling past me into the bucket at my feet was excessive. The woman was going into shock. If you take a pulse and blood pressure at this point, her heart will be beating very rapidly, trying to keep up with the blood loss and keep her blood circulating, and her blood pressure will drop. In this situation, she needs immediate intervention. Nowadays, we've got much better at estimating blood loss, and we don't let blood trickle away into a bucket at our feet, hidden under sheets. We have a drape that collects the blood. We can visibly see, calculate and weigh exactly how much blood she's losing and at what rate. We're much more conscious of the importance of a woman's weight. If a woman who weighs 90 kilograms loses 2 litres of blood, it's very different from a 2 litre blood loss in a woman who weighs 50 kilograms, as her circulating blood volume will be significantly less if she weighs less. Part of the problem with blood loss is it can be unpredictable. Some women will be more at risk of blood loss, and we will discuss this when we take handover on the labour ward. and we will think about how we're going to try and prevent that blood loss. But what is more difficult is the unpredicted blood loss. The woman that we haven't prepared for, and we have to react extremely quickly. Remember, I said 0.5 litre a minute going through the placenta. That's literally like turning a tap on if you let the blood flow and you don't take action fast. Because this is such a critical maternity emergency, all hospitals have very strict protocols on how we deal with blood loss. We have a fast bleep system so that we can put out a hemorrhage call and call all the team that we need: anaesthetics, haematology, blood transfusion, obstetricians, midwives, all to that place within seconds. We can manage it proactively. We have proformers that tell us exactly what treatment to give, in what order to give it, in what dose to give it, who to call to come and help manage it. And we practice blood loss scenarios in our annual maternity training. So to some extent, blood loss is our most common emergency, our bread and butter. For today's zesty bit, I want you to pause a little. Think about the woman's perspective. How must this feel to her and her birth partner? As a maternity member of staff, remember the most important thing in this situation is to keep calm and keep talking to the woman and her partner. Calm, systematic treatment is key. Constantly explaining to the woman and her partner what you're doing and why. I've had couples comment to me when I've seen them postnatally that there was a general air of panic. Blood was going everywhere. People were talking over each other. People didn't know what they were doing. And then I entered the room, the consultant, and they felt the whole atmosphere change. Women and partners will not feel frightened if you're assuring them that you know what you're doing, that you've done it before, this is what you've trained for. It's particularly important to allocate a member of staff to look after the woman's birth partner. Sometimes we're very focused on the woman. She may be in and out of consciousness. She may be less aware of what's going on. It may be her partner who's traumatised, feeling unable to help and fearing for their partner's life. One of the things I love is reading. And there's a brilliant author, Maggie O'Farrell. In one of her books, The Hand That First Held Mine, she writes an amazing description of a woman recovering from a hemorrhage, from blood loss at an emergency caesarean. I hoped I might be able to share excerpts of it for you in this episode. However, I've discovered that getting permission to do so is a little bit more complicated than I'd anticipated. So I will just have to tell you that the first few chapters are very much worth a read. The woman describes from her perspective, lying on the operating table with her hands folded, whilst activity and panic is unleashed around her. She picks up on not only what people are saying, but how they're saying it. That gives her an idea of people's competence or not. She is aware of the maelstrom of activity rushing around her, with her at its centre. She is aware and fearful that something has gone terribly wrong. I think sometimes in our relief as maternity staff, once the bleeding has subsided and we have the situation under control, we dust ourselves off, pick ourselves up and carry on. For us, it might be a weekly occurrence. For that woman, it's once in a lifetime. It may have been very scary. Even the word she heard, hemorrhage, may be terrifying. We expect the woman and her partner, in the days that come on the postnatal ward, to pick themselves up, get out of bed, look after their baby, behave as if nothing's happened. That's quite a big ask. It's important that we go through with the woman and her partner, once, twice, however many times she needs, what happened, why it happened, what treatment she had, and why it will all be okay. If you're a pregnant woman listening to this podcast, I hope this hasn't frightened you. I hope it's helped you feel informed. Yes, hemorrhage is unpredictable, but you can help yourself by keeping yourself in great shape during pregnancy, eating the right things in your diet, taking iron supplements if needed, getting your blood count to a good level, and know that we have clear systems and processes to manage. Don't be frightened if we're calling for extra pairs of hands, bleeps start going off, and people rush in, either to the room or to the operating theatre. That's a swift response for your safety. We're all there to do a job and minimise your blood loss as soon as we possibly can. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FW or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.